Welcome back to another episode of the AJNR podcast. Today we have a special guest, Amir Khadivi, who is a neuroradiology fellow at Johns Hopkins with me. A style of prior podcasts many years ago was to have the podcast editor discuss with the neuroradiology fellow that they work with in real life. And today we're doing exactly that. The article we're discussing today is the impact of clinical and radiologic factors on CTP timing in acute ischemic stroke. This is a recent article in the AJNR January issue. The first author is Bernardo Proner and the last author is Matteo Bonatti, both from the teaching hospital of Paracelsus Medical University in Bolzano, Italy. Without further ado, please take it away, Amir.
Thank you so much, Dr. Deng, for inviting me to do this podcast. I just want to give a little shout out to our fellowship program and those that are considering applying to neuroradiology. I think the Johns Hopkins radiology program is a fantastic fellowship program with wide, diverse pathologies. And so for those that are thinking about applying to neuroradiology fellowship, please think about the Johns Hopkins neuroradiology fellowship program. So thank you so much. And without further ado, let's jump into this. So CT perfusion is useful in the setting of acute ischemic stroke, providing information on the extent of infarcted cerebral tissue and hypoperfused severely ischemic, potentially salvageable tissue, which is commonly termed penumbra. It is also particularly useful in determining management when time from symptom onset is unknown or if it exceeds 6 hours. Recommendations for CT perfusion scan duration vary among studies, with durations ranging from 40 to 90 seconds. Short scans result in truncation of the concentration measurements, potentially resulting in inaccurate CT perfusion results. Ideal scan duration is one which prevents truncation but also minimizes radiation exposure. So the goal of the study is to evaluate how various clinical and radiologic factors, including but not limited to age, arrhythmias, and type of vessel occlusion, affect diagnostic quality of CT perfusion, and CT perfusion parameters such as the vascular time to peak in the context of anterior circulation acute ischemic stroke. So the authors created an IRB-approved single institution retrospective observational cohort study. The initial cohort included 316 patients who underwent non-contrast CT and CT perfusion between January 2020 and April 2024 with clinical suspicion of anterior circulation acute ischemic stroke. Exclusion criteria were the presence of severe motion artifacts compromising the diagnostic value of the study, diagnosis of acute seizure, neoplasm or hemorrhage, other diagnosis ruling out acute ischemic stroke, or lack of clinical documentation. The final patient population included 295 patients, of which 161 were women, 134 were men, with a median age of 79. Clinical parameters obtained included age, blood pressure, NIH scale score at the time of admission, and diagnosis of arrhythmias, which was given particular attention. 2 radiologists analyzed the arterial input function and the reference vessel curves, or the venous output function curve, and CT perfusion was considered diagnostic if at least 3 time points were measured before arterial input function rise and 1 after the reference vessel curve returned to equilibrium, as per vendor guidelines. If disagreement occurred, a consensus was reached. Additionally, the vascular time to peaks were measured for each patient. Non-contrast CTs were evaluated for microangiopathy on a scale of 0 to 4 based on the Van Swieten CT scoring system. Presence of intracranial atherosclerotic calcifications and the presence of endotracheal tube/intubation status was also noted. CTA images were assessed for vessel occlusion, including large vessel occlusion, which were distinguished from more distal vessel occlusions. So in terms of the protocol, CT scans were performed on a 128 slice single source scanner. The CTA scan extended from the ascending aorta to the vertex after administration of 50 milliliters of non-ionic contrast agent at a flow rate of 4 milliliters per second, followed by a saline chaser of 30 milliliters. A bolus tracking technique was used with the region of interest in the ascending aorta and a trigger of 100 Hounsfield units of attenuation. CT perfusion was acquired after administration of 40 milliliters of non-ionic contrast agent injected at a flow rate of 6 milliliters per second, followed by a saline chaser of 50 milliliters. 4 seconds after the start of the injection, a series of 30 consecutive scans, one every 1.5 seconds, was initiated. So the authors also included examples of normal arterial input function and reference vessel curves. And for those that are not watching the podcast, basically the important thing is the arterial input function curve should peak earlier and lower than the venous output function curve, and both should downslope and level off until a new baselines are established. And this is what they showed in their example. It also provided an example of a truncated curve, which showed the reference vessel curve not reaching equilibrium before the scan was terminated. Additionally, the authors provided an example of the Van Sweeten system used for grading microvascular ischemic changes on non-contrast CT, with a Van Sweeten score of 0 showing no white matter lesions on CT, the Van Sweeten score of 1 showing unilateral multifocal lesions, a Van Sweeten score of 2 showing confluent unilateral lesions, a Van Sweeten score of 3 showing confluent unilateral white matter lesions and contralateral multifocal lesions, and a Van Sweeten score of 4 showing bilateral confluent white matter lesions. In terms of the statistical analysis, demographic and clinical data were summarized using descriptive statistics, measures of variability, and precision. Initial univariate analysis performed to evaluate impact of various clinical and radiologic variables on diagnostic value of perfusion. Variables with a p-value of less than 0.1 in the univariate analysis were included subsequently in multivariate logistic regression to account for confounding factors. Odds ratios for non-diagnostic examinations were also estimated. The validity was assessed using a Hosmer-Lemschau test. In terms of the results, CT perfusion was of diagnostic quality, i.e. without truncation of the arterial input function and the reference vessel curves in 192 examinations, while CT perfusion resulted in truncation of these curves in 103 examinations. In all cases where CT perfusion was deemed non-diagnostic, this was attributable to early truncation of the arterial input function and reference vessel curves. The authors provided a table of the univariate analysis. And in terms of the clinical variables that were included, these variables included sex, age, NIH scale score, systolic and diastolic blood pressure, heart rate, presence or absence of arrhythmia, the scale of microvascular ischemic changes based on the Van Wheaton scale grading system, the arterial wall calcifications, presence or absence of an endotracheal tube, and whether there was a large vessel occlusion or not. 6 variables, age, NIH scale score, arrhythmia, the presence or absence of arrhythmia, the degree of vascular ischemic changes, arterial wall calcifications, and the presence or absence of large vessel occlusion, showed statistical significance in predicting the diagnostic quality of the CT perfusion study. These 6 variables were included in the multivariate logistic analysis. 2 variables, the presence or absence of arrhythmias, and age showed statistical significance in determining diagnostic quality of the CT perfusion study. Specifically, patients with arrhythmias had 3 times the odds of undergoing a non-diagnostic exam compared to those without arrhythmias. Age was also found to be an independent predictor with modest but statistically significant increase in risk per year of age. More specifically, approximately 5% increase in odds of having a non-diagnostic exam for every 1-year increase in age. Additionally, the authors looked at arterial time to peak, which was higher in patients with cardiac arrhythmias compared to those without cardiac arrhythmias. The median time to peak for patients with cardiac arrhythmias was 24 seconds, with an interquartile range of 20.2 to 27.1 seconds, whereas for those without cardiac abnormalities, the median time to peak was 18.6 seconds, with an interquartile range of 15.5 to 21.7 seconds. And these differences were statistically significant with a p-value less than 0.001. Additionally, the venous time to peak was higher in patients with cardiac arrhythmias. Median venous time to peak was 30.2 seconds with an interquartile range of 26.4 to 32 seconds for patients with cardiac arrhythmias compared to 25.6 seconds with an interquartile range of 22.5 to 28.7 seconds for those without cardiac abnormalities. And this difference was also statistically significant. To summarize, there's a strong association between cardiac arrhythmias and delayed arterial and venous time to peak values. This is attributable to irregular cardiac output characteristics of the cardiac arrhythmias, which disrupts consistent cerebral blood flow and reduces the reliability of the perfusion maps. Similarly, older patients are more likely to have non-diagnostic CT perfusion scans. This is hypothesized to possibly be secondary to higher prevalence of cardiac dysfunction, i.e. reduced ejection fraction in these patients. This study highlights the impact of patient-specific factors, particularly cardiac arrhythmias and age, on the diagnostic accuracy of CT perfusion imaging in acute ischemic stroke. Most patients do not benefit from longer scan times, often requiring a scan shorter than 45 seconds for optimal time attenuation curves. Instead of applying fixed scan duration protocols, authors suggested considering adaptive imaging protocols that adjust based on real-time bolus arrival detection to enhance diagnostic reliability and minimize radiation. And of course, this is of particular importance in younger patients, which are more radiosensitive. Also recommend the use of integrated automated algorithms that incorporate heart rate variability and arrhythmia history into CT perfusion processing software. In terms of the author's study limitations, this is a single-center retrospective study, which is limited in its ability to determine causality and generalizability. The CT perfusion diagnostic quality was based on technical criteria provided by the software vendor, rather on direct assessment of clinical impact. Ideally, diagnostic quality should be evaluated with respect to clinical decision-making outcomes, such as those set by the frameworks of Diffuse 3 or the DAWN trial. However, in this study, standardized clinical outcome data and consistent treatment eligibility assessments were not always available, and follow-up imaging varied. Additionally, the authors note that the median NIH scale score in the study population was low, with the NIH scale score of 8, with many patients presenting with milder clinical symptoms. Overall, I thought this was a very interesting paper that tackled an important topic. It would be interesting to perform a similar study, but to also include left ventricular ejection fraction as a variable in determining diagnostic quality of CT perfusion and its effects on the CT perfusion parameters. It would also be interesting to see how pre-scan interventions, such as use of fluids, vasopressors, or antihypertensives, affect the time attenuation curves and other CT perfusion parameters. In terms of the statistics, I thought it would be interesting to see an analysis of the inter-observer variability for classifying a study as diagnostic or non-diagnostic by calculating, for example, a kappa statistic. So these were just some of my thoughts on the paper. And I ultimately want to thank the authors for their contributions and thank the audience for taking their time to listen to this discussion. And I was going to ask you what you thought about the paper, Dr. Deng.
Thank you so much, Amir, for that summary and discussion. I think I really have a good understanding of this paper now, but tell me if I have everything correct. So basically, the authors did a retrospective study on their CT perfusion analyses done for acute ischemic stroke concern. And they found that a significant minority of their scans were considered non-diagnostic due to early truncation of the arterial input function and venous outflow function curves. And so when they analyzed the clinical and radiologic factors that were associated, they found that some things that we already knew anecdotally, that there was a significant association of early truncation with older age and cardiac dysfunction, here mainly looking at cardiac arrhythmias. And so the authors suggest that perhaps we should have a more tailored approach to setting the duration of the scan of CT perfusion in order to ensure that the patients who are older and have cardiac arrhythmias don't have that non-diagnostic truncation of those curves. I will say that, compared to my experience, their rate of curve truncation in non-diagnostic CTPs is higher than what I've experienced, and that may be due to differences in technique and protocol. At Hopkins, if I recall correctly, our scan duration is 60 seconds, whereas the authors limited theirs to 45 seconds. So you can imagine a significant portion of those curves, may not return to baseline until the 45 to 60 second mark if they have any kind of cardiac dysfunction. And I totally agree with you. As another factor that should be assessed if they had the data would be left ventricular ejection fraction, because there are a lot of patients with heart failure who don't necessarily have dysrhythmias, who will also have broadened and delayed arterial input function curves. So that's a significant factor. It's not assessed in this study.
That was a fantastic summary, and I totally agree. And in this day and age where, I feel like we get echocardiograms all the time, I feel like that data about the ejection fraction could certainly be investigated for future studies.
Yeah. So in terms of practical implications for the listeners, perhaps it would be prudent to prolong your CTP acquisition duration. It comes at a trade-off of higher radiation dose for everyone until the day that we have some way to more closely tailor our CTP acquisition durations based on the patient's cardiac factors. For instance, real-time monitoring, and maybe there would be some way to automatically prolong the acquisition up to 60 seconds in order to ensure diagnostic images.
Exactly. And in this world of AI and machine learning, maybe incorporate some of these tailored approach in the scan duration for patients that get CT perfusion.
Thank you so much, Amir, for joining us today on the AJNR podcast. And listeners, I hope you have the opportunity to check out the full article on the AJNR website. Until next time.